Hello, I'm here today to talk about repeat prescribing in general practice. I wanted to share this with you. I'm part of a group that are looking to develop resources for GP surgeries looking to review their processes around repeat prescribing, and I wanted to share with you a quality improvement project I've been involved with at our practice, looking at a month of birth recall and review process. So I always think a picture tells 1,000 words, and in terms of the role of the pharmacy team in general practice, I think this picture sums it up best. We pride ourselves on being the tiny ship of order, bringing a sense of calm and neatness and strategy to the otherwise vast sea of chaos that is general practice. I think it's quite useful to consider the objectives of the practice as fitting into two main streams. The hot stream of clinical activity, so all of the urgent, acute and chronic, exacerbations of existing conditions and new and differentiated presentations. And then the cold stream, so the more strategic and organised planned healthcare that can be delivered to specific cohorts. And I would say that the greatest contribution really we felt that the pharmacy team could make would be to this cold stream. And so our project that I wanted to share with you today looks to produce a toolkit for GP practices to review this cold stream and to consider how they can improve the patient's outcomes and experiences in terms of their planned evidence-based healthcare, and looking at managing the flow, I suppose. Whilst it's impossible to turn off the tap and reduce the volume of work flowing into a general practice, if you can bring some order to the vast sea of chaos, that feels more manageable, and also to make best use of the entire clinical team and the varied skills that will present in different practices. So I think the first thing that we used quality improvement methodology around Kaizen, so that's from the Japanese word meaning good change. If there's one thing we've all experienced, I think, through the pandemic and beyond, is that not all change is good. So how could we make sure that we used some theory and some methodology to really get behind properly understanding the existing process as it was, and then using opportunity costing, swim lane mapping to map that process, and then design new processes and run those on paper first. So making those mistakes, if you like, in theory before rolling them out in practice. So the way that we did it as a case study, we were looking to reduce that complexity and, as I say, manage the manageables. We're a medium to large size practice. We've got roughly 12,000 list size. So how could we look after all 12,000 people and spread them evenly throughout the year? We happened upon the idea of having a one-stop shop. So previously, an asthmatic diabetic on a DOAC would have had 3 different reviews at 3 different times for those 3 different conditions, and we thought, well, perhaps we could organise it so that people are seen once on a one-stop shop as a holistic review, and in order to spread the workload evenly throughout the year, those 12,000 patients, if we synchronise that review to a patient's birthday, then that would spread our 12,000 patients down to 1,000 a month and make that again feel more manageable. The advantage to that is that it improves engagement. The patients know when their birthday is, and there was improvement in engagement and an understanding of the new birthday MOT as it became known. And then we were looking to fully utilise the whole practice team, and through our swim lane mapping, we were able to cost in the opportunity of having a pharmacy technician providing a pre-review. So she would review the patients in advance and allocate them to the most appropriate clinicians, and order bloods and observations as appropriate to their medication, but also to the disease registers that they're on. It felt that would then be more satisfying in the sense that those reviews would be more structured and more planned, and with the most appropriate clinician matching to their scope of practice. And when we first started to roll that out, we were aiming to remove the demands of this sort of recall and routine reviews, chronic disease management from our limited GP time. We were also looking to make efficiencies around our phlebotomists, who were asked to take blood tests at random times throughout the year, often repeatedly for the same patient if they were on more than one disease register. And as I say, there was uneven workload throughout the year. There was a rush around year end to get people through their annual review in time for the contractual obligations of the GMS contract. And this way, it gives us assurance that we've built in a structured review process around a patient's month of birth, so that we know that we're not going to miss anyone and leave anyone behind. So there were other benefits that we hadn't expected when we first designed it that came through as we ran the process at the start. So the patients very quickly took the idea to heart and became familiar with the idea that around their birthday they would have what came to be known as their MOT, and the clinicians felt more satisfied too. It's a lot better to have all of the blood results and the observations all in hand when you come to do a structured medication review, rather than having to go back and have duplication of effort if you're asked to review a patient and then order bloods at that point and then have to call them back in again if those bloods are found to not be satisfactory. And there was less sort of failure demand, if you like. So the number of prescription queries that we had were less, the reauthorizations that were coming to the pharmacy team were less, as we managed to synchronise everyone's repeat medication to their annual review at the same time, using repeat dispensing wherever possible. That whole process became more efficient and leaner. And also because we were proactively calling in our patients in the month of their birthday, it meant that as part of the standards in the contract at that time were access standards. So put bluntly, how quickly we were able to answer our phone to incoming calls. Well, when we took ownership and were making outbound calls for these routine recalls and reviews, that removed some of that failure demand and therefore improved our performance, with fewer patients having to contact us when they were running short of their medicines or overdue their review. So, as I say, I was approached by AWTTC, having been part of that initial scoping project at my practice, to think about how could we produce a toolkit or some resources that would be useful to general practice that are thinking about exploring these possibilities as well. So I'd be very keen to hear from other practices that have implemented a similar structured recall and review and repeat prescribing process. And although we've had the first meeting of the Short Life Working Group looking at how best to develop these resources, I'd still be really keen to hear from anybody that would be happy to be part of this work going forward. We're hoping to develop some resources over the coming months and then present them at AWMSG for their expert review, and then ultimately produce things that will be useful, pragmatic and practical guidelines for practices to use to redesign their services. So my email address is just there, and I'd be very glad to hear from anybody who has experience in this area and an enthusiasm for both quality improvement, repeat prescribing, recalls and reviews. Thank you.